So bear with me while I just allow a few more people into the room. Welcome everyone, particularly those who have just joined us. And if it's your first time here in our webinars, welcome. Today's session, we're covering advancing arthritis therapies. I just ran through some general housekeeping and very quickly, if you don't mind switching your microphones onto mute, that would be fantastic. These sessions are recorded. So if by any chance you need to leave this session and watch a recording later in your own time, please feel free to do so. We'll send out the recording to your emails directly to 24 hours post-webinar. Great to see everyone dialing in from all over New South Wales and Queensland. It's excellent. We've got such a good turnout. Today we will be talking a little bit about novel biologic therapies, regenerative and cell-based therapies, integrated lifestyle therapies, and some of the emerging research around all these treatments. It's a very grey area in terms of treatments that are available to cure osteoarthritis and rheumatoid arthritis, but there is a lot of promising research coming out, and that's what I hope to share with you today. Just a disclaimer, all these presentations do contain really general information and advice, and we do make sure that the information we share with you is accurate. Now, we aren't here to substitute any individual treatment advice of your doctor or healthcare professional. So if you do have questions that relate to your own treatment plans, I will encourage you to always go ask your primary healthcare provider. But in saying that, we have a chat box where you can ask all your questions in relation to the content of the presentation, and I'll do my best to help you out. Before we begin, I do want to acknowledge the traditional custodians of the land in which we gather today. We pay our respects to their elders, past and present, and recognise their continuing connection to land, waters, and culture. We extend this respect to all First Nations peoples and acknowledge their invaluable contributions to community knowledge and well-being. Okay, so if it's your first time in our webinars, let's just start with a basic understanding of what is arthritis. A question that comes up from time and time again, especially if we're newly diagnosed, but it is a broad term that encompasses conditions that cause a lot of joint pain, stiffness, swelling, sometimes decrease in joint mobilities. I'm sure some of us can relate to some of these characteristics. The two most common types of arthritis that do afflict most of us today include osteoarthritis and rheumatoid arthritis. So sometimes when I speak to those two, it's just because they're the types of arthritis that dominate. But there are so many other types of arthritis, including psoriatic arthritis, Sjogren's, ankylosing spondylitis, juvenile idiopathic arthritis. We get told this is a condition that affects mainly older people, but it's not a condition that discriminates. It affects everyone from children and teenagers, young adults, older adults. Now, each type of arthritis has its own unique features and their own treatment protocols. But in saying that, a lot of these types of arthritis are managed in very similar ways. So you'll see a lot of overlap in the recommendations that are spoken about to manage the condition. Osteoarthritis can be very effectively self-managed with things like exercise, physical therapies, analgesia. Inflammatory types of arthritis can be effectively managed with drugs that halt inflammation, but there are no cures at the moment for any types of arthritis, but there are a lot of treatments on the horizon, and that's where I want to focus today's presentation on. So just like any long-term condition, your management plan should ultimately be called what we call person-centered. So if we look at the guidelines and the ideal plan of management that everyone should be getting in care upon diagnosis, it should include education about the disease, how you can manage it yourself, the promotion of physical activity and therapeutic exercise. If it's relevant, then weight management has a role as well. If you have the autoimmune type of arthritis and inflammatory type, then we can layer medication into the treatment regime. This medication is intended to suppress disease activity, and ultimately the goal is remission. Now, in every clinical guideline, education, exercise, and weight control all fall into your first line of defense. Second line of management, often driven by an increasing need of symptom relief. So strategies like assistive aids, complementary or alternative therapies, pain relief medication, assistive device, all these things can be laid into this second line of management. The third line of management or treatment, it's not intended to suggest this as an outcome for everyone, but some people, surgery has its place, and they do say that it has its place for the right person at the right time, and it can be very effective. But it's really important that this decision has been made through a really formal decision-making process with your healthcare provider. And it's involved weighing up the risks, the benefits. We've ensured that evidence-based non-surgical interventions have been explored prior to surgery. So you can be absolutely sure that you've tried everything to reduce pain, improve mobility, and then in that case, the surgery is warranted. So all of these tools you're seeing here and treatment strategies are backed by evidence at different levels, but they're intended to help with the management of disease, and they're there to help prevent the arthritis from worsening, impacting your quality of life, even causing disability. So we have grade A evidence that suggests physio is great for everyone. If you're overweight, then maybe a weight loss intervention can be very effective for things like pain relief. And then you have medications that are effective for inflammatory types of arthritis, but they do vary in efficacy and tolerability for a lot of people. So that just means that whilst it's very effective in the evidence, it doesn't necessarily translate clinically. For some people, there is a lot of individual factors at play. And so the drugs don't work the same for everyone. Now, for osteoarthritis, we don't have any disease-modifying osteoarthritis drugs on the market at the moment, but we have a lot that are under investigation for holding promise. So this is where we talk a little bit about something called osteobiologics, which fit into the treatment pyramid here as an emerging option that could potentially complement or even modifying existing management strategies. Some osteobiologic treatments like PRP therapy, if you've heard of it, or hyaluronic acid injections, these are being explored as non-surgical interventions to help with symptom relief. But then we have more advanced osteobiologics under investigation, such as stem cell therapies, which are being studied for their potential to actually target the disease activity in osteoarthritis. So they're being investigated for their abilities to repair cartilage and slow disease progression. So really interesting area of research. So we've had researchers that have been investigating disease-modifying agents for osteoarthritis for decades now. So while no drug has yet been approved, specifically as disease-modifying osteoarthritis drugs, the research landscape at the moment is more promising than ever. And there have been a lot of advancements in regenerative medicine, gene therapies, and drug targeting technologies. We don't always hear about them, but occasionally they might pop up on the news or in your Daily Mail articles, and you know, they will speak to going well beyond traditional pain management. For rheumatoid arthritis and other inflammatory types of arthritis, such as psoriatic arthritis or ankylosing spondylitis, new therapies are focused more on achieving better long-term disease control, serving as an alternative to the current medications that are on the market but have become ineffective for some people due to either disease severity, increased tolerance or resistance, and challenges adhering to the medication. So as you can see here in this list, there are so many different treatments under investigation, and where these are all at in terms of implementation, they vary, and it depends on things like clinical trial success, regulatory approval, long-term safety data, there's economic considerations, but also healthcare system readiness. So things like gene therapies or stem cell therapies, sometimes they require specialized administration and close monitoring. Access to infrastructure can also impact how quickly a treatment becomes available. But then there's also the patient education and physician buy-in. So patients and physicians need very good education on the benefits and potential risks of new treatments, especially with complex therapies like biologics or regenerative treatments. So often the process from early development to market release for rheumatoid arthritis and osteoarthritis treatments can take over a decade, which is why sometimes when you're hearing about these treatments in the news or in articles, usually it's because of the early clinical trial results, FDA designations, or breakthroughs in preclinical research. So while the media coverage can create a lot of buzz and excitement and intrigue, it's really essential that we're viewing these reports and these articles with a lot of caution, because even though it's in the news, it doesn't necessarily mean it's close to being available in our local clinic or being fully approved for use. So some of the emerging therapies I really want to focus on today are the ones that have been hyped up recently and are often being asked about. And so this gremlin therapy, for starters, did anyone hear about this treatment in the news last year on Channel 7 or in the Advertiser? Did this come across anyone's TVs?
No.
No? Okay, so this is this hit the news due to the research progressing really well at the University of Adelaide. Just to give you some background, in 2023, researchers selectively depleted some specific cells that play a really crucial role in maintaining cartilage structure and function in mice. So these cells are called GREM1 lineage cells. When they were depleted, the researchers actually discovered that osteoarthritis-like symptoms began to advance in the mice, and they also observed structural changes eventuating that are often seen in people living with osteoarthritis. So it led to the hypothesis that GREM1 cells may have some kind of protective role against osteoarthritis and contribute to the preservation of cartilage. So super exciting for everyone involved. The researchers then tested whether stimulating the GREM1 cells could reverse the osteoarthritis-like symptoms. So they administered a drug called sprifurmin, which is essentially a lab-made version of a natural protein in the human body that helps cells grow and repair. You can think of this drug like a special fertilizer for the cells in your joints, helping them to repair and maintain cartilage. So when they were able to successfully boost the growth of these GREM1 cells, the treated mice showed significant recovery in the cartilage thickness and reduced signs of osteoarthritis. So moving forward, this drug has been under investigation for about 10 years, but it's the forward study that holds significant importance in the field of osteoarthritis research for a number of different reasons. Sorry, I'm just letting some people in. So one, it is the longest disease-modifying osteoarthritis drug trial conducted to date. This has spanned over 5 years. There were 549 participants involved with moderate knee osteoarthritis. But one of the most notable aspects is that it is the first trial to evaluate the post-treatment effects of a disease-modifying osteoarthritis drug. So sprafirmin demonstrated structural benefits, so increased cartilage thickness, and it persisted for up to 3.5 to 4 years after the last dose. So this suggests that sprafirmin may not only provide short-term structural improvements, but offer some long-lasting benefits, which is very critical for osteoarthritis patients who are seeking to slow disease progression. Despite the cartilage gains, the pain and function scores that were assessed, they didn't show any significant difference between this treatment groups and placebo groups. Some patients reported modest symptom relief, but it wasn't consistent across all doses or proven to be any better than a placebo. So sprafirmin is now currently in phase 3 of the trials. The focus is much on reversing the degenerative aspects of osteoarthritis. So the researchers here are really optimistic that if it is successful, sprafirmin could become available for clinical use in the next coming years. It could offer a regenerative therapy rather than merely just symptom management. I do want to say that some of the limitations here, the discovery is limited to animal models. There are genetic similarities to humans, but we do need the human trials now to see if the positive effects translate to really long-term sustainable outcomes. And if this therapeutic pathway leads to addressing the root causes of osteoarthritis, it could actually be a breakthrough in joint health treatment. So that's why it pretty much made the news. If you haven't heard of Loresivant, this is pretty much an experimental drug injected directly into the knee. It works by targeting a specific biological pathway involved in cartilage damage and repair. So it's intended to help change how osteoarthritis actually affects the medial compartment of the joint. Both the LAW phase 2B and the osteoarthritis 07 trials have played a massive role in advancing research on Loresivant as a potential treatment for knee osteoarthritis. So the LAW phase 2B trial was a 24-week study. It was a crucial step in identifying the optimal dose of this drug for managing osteoarthritis symptoms. Researchers in this trial tested multiple doses and determined that 0.07 milligrams provided the best balance of pain relief and improved function. The results from this study helped shape the design of the later trials, confirming that this drug could significantly improve patient-reported outcomes. This was a key moment in establishing Loresivant's potential as a symptom-relieving treatment. So while these results were super promising for symptoms, the drug helped reduce pain. It could be promising for improving quality of life and function. It showed that people had better function, meaning they were able to move more easily or do the activities that were once difficult. The only tricky part here is that it didn't show any changes in the joint structure. So there was nothing demonstrated like increased cartilage thickness. But this could be because it was really short in duration. 24 weeks isn't usually long enough to observe any kind of positive structural changes in the joint, but it did help manage symptoms, which is still a very valuable finding. So building on the phase 2B findings, the osteoarthritis 07 trial took the research further by evaluating long-term efficacy and long-term safety. So instead of just focusing on symptom relief, the study examined whether repeated injections of Loresivant could be key to slowing down joint damage over time. So currently this drug is in phase 3, but it is a long-term extension trial to further evaluate its long-term effects and its safety. And they're looking at the long-term effects more so on pain and functionality in a broader patient population with a focus on less structurally damaged group of patients. So pain is a primary outcome being measured here. but the study is more focused on evaluating long-term efficacy. The integrated analyses from other different trials suggest lurescent has a good safety profile with the side effects similar to any kind of injection received, you know, swelling at the site, redness, a little bit of pain. And while it continues to show potential as a disease-modifying treatment for knee osteoarthritis in terms of improving pain and function, we need a lot more ongoing studies to fully understand its role and if it can be implemented in clinical practice. Just admit some people. So tissue gene C, another regenerative therapy. It is a cell and gene therapy designed specifically for treating knee osteoarthritis. So it involves using genetically modified cells to promote cartilage repair and regeneration. It combines human chondrocytes with cells engineered to produce something called transforming growth factor beta. So basically, it's a type of treatment that takes the cartilage cells and changes them so they produce a more special protein that helps with the cells grow and heal, which is very important for maintaining cartilage. So the tissue gene C study involved over 163 patients over the course of 52 weeks. And they focused on how well the treatment helped reduce pain, improve knee function, and potentially modified the underlying joint damage in knee osteoarthritis. So those receiving the treatment reported significant improvements in pain and knee function at different points throughout the year compared to those who received a placebo. There was imaging involved in measuring the outcomes, and the imaging results suggested trends toward thicker cartilage, slower bone surface growth, and with treated patients showing lower levels of biomarkers found in the blood and urine that indicate cartilage damage. So these findings suggest that the treatment may slow down the damage process in the joint, although further studies are needed to confirm these effects. So while some participants experience mild side effects, again, like the usual side effects we see, swelling and joint pain, these were generally manageable. The treatment holds a lot of potential here as a promising option for osteoarthritis, helping not just the symptoms, but also underlying joint issues involved with osteoarthritis. Now, this study, it did face a lot of regulatory challenges, so they put the whole study on hold when they found out one of the key ingredients in this treatment was it came from kidney cells instead of the intended cartilage cells. So they tested all, they paused all testing here, but since then the FDA has actually allowed the phase 3 trials to proceed. So they're looking at conducting this in about 1,000 patients, and they're closely being monitored over the next 2 years to evaluate long-term effectiveness and safety of the next treatment. Sorry, can you guys hear me okay? I know the rain's hit us really hard at the moment, so.
Yeah, and it's hitting me too in Bondi.
Okay. Perfect. If anyone is having trouble hearing me, just let me know and I'll pause the recording and try sort it for you guys. Okay. Now, PRP, has anyone asked about this treatment for their own treatment regime? Has anyone had these conversations with their primary healthcare provider?
I did. Peggy speaking.
Hi, Peggy. You
Hi.
did?
Yeah, look, a few years ago I had it, but that was a few years ago. So.
Yeah. I'm surprised so far it's just you. I know in the chat box a few people have inquired about this, and
Yeah.
the reason I asked you guys is because it's often asked about in a lot of clinics. We get a lot of questions about this over our info line, but platelet-rich plasma injections, it's gained significant popularity in Australia, especially in the field of cosmetic treatments and sports medicine.
Yeah.
Now, many people with arthritis are exploring PRP as a treatment option due to its claims in helping alleviating pain and promoting healing, by using growth factors from your own blood, and its popularity is rising. So some studies suggest benefits over traditional treatments like corticosteroid injections and hyaluronic acid. But as you can see here, opinions of the researchers vary, and it's because the scientific evidence supporting the effectiveness of PRP remains very mixed. Some smaller clinical trials have reported really positive outcomes, but it's the RESTORE trial which continues to guide the clinical guidelines today. It was a very significant study involving 288 people over 12 months. The findings indicated no difference between PRP and saline placebo injections. And so the pain reduction scores or disease progression, there was no significant difference. There were no changes in cartilage volume. And because this RESTORE trial was such a high quality, rigorously designed study, it did not support the efficacy of PRP. So the study challenges the popular assumptions around its use as a critical regenerative medicine and adds a lot of caution to the clinical use of PRP. So it has had a very strong influence on clinical guidelines, and currently it's not recommended by any physicians or rheumatologists, and this aligns with the broader recommendations from the Australian Commission of Safety and Quality in Healthcare and the Australian Rheumatology Association. So this is just because there's a lack of demonstrated long-term benefit. When you look at how much it costs to receive this treatment with limited effectiveness, it's not really the best option to explore. So often, until there is a good body of evidence behind a treatment, it will remain poorly funded and can remain really hard to access. So at this point in time, decisions on using a treatment like PRP for osteoarthritis in the knee factors in several considerations, whether alternative treatments like non-steroidal anti-inflammatory drugs or corticosteroids can provide better short-term pain relief, and cost effectiveness. And especially with the cost of living these days, costs on the rise, you want to make these decisions carefully, always weigh up the pros and cons. So
sorry, can I ask a quick question?
If you can hold off until the very end, is it Karen?
Yeah, it is. Hi.
Yeah, pop it in the chat group and then we'll circle back to questions at the very end.
Okay.
Thank you. So the Proximod of clinical trials are focused on evaluating safety and effectiveness of Proximod, which is a drug currently being investigated for the treatment of rheumatoid arthritis. So it's being studied as a potential new therapeutic option, particularly for people who don't respond really well to treatments like methotrexate, biologics, JAK inhibitors, and so on. These current treatments often work by suppressing immune activity, but not all patients experience adequate symptom relief or halt disease activity effectively. Some people can even develop resistance or intolerance to some of these medications, which is why we need to look at alternative therapies. So in rheumatoid arthritis, the immune system mistakenly attacks joint tissues, which causes inflammation and damage. Now, Proximod is believed to work by activating a specific molecule that reduces the activity of immune cells involved in the inflammatory process. So I want you to think of it like acting like a gatekeeper, controlling the movement of immune cells to help reduce inflammation, similar to how a traffic light manages the flow of cars to prevent congestion. So Proximod has completed early phase trials where both healthy individuals and rheumatoid arthritis patients received a consistent daily dose of Proximod or a placebo over a 28-day period. During these trials, the drug showed stable levels in the blood, suggesting it was consistently present and likely interacting with its target over time. So this drug is currently in phase 2, It's met basic safety and efficacy criteria, and it's promising in this area, but further research is needed to assess long-term effectiveness, evaluate its safety profile in larger patient populations, determine the optimal dosing regimes, and if there's any future implications we need to consider. So just like any new medication, the results of these clinical trials are always crucial in determining its role in the treatment landscape for rheumatoid arthritis. Has anyone been able to find anything interesting on probiotics and the link with rheumatoid arthritis or osteoarthritis? Is it a treatment of interest to many here? It's gaining a lot of traction in the nutrition space and the gut health space, but research on probiotics and their effects on the gut microbiome in relation to managing osteoarthritis and rheumatoid arthritis is a growing area of interest, but the exact mechanisms of how probiotics work are still not fully understood. And I'm not sure if we ever will fully understand them because of how complex the nature are around probiotics. There are a lot of misconceptions and oversimplifications around how probiotics work, particularly in relation to inflammation and helping things like weight loss and disease activity. So there is increasing evidence supporting potential health benefits, especially as more research suggests that gut health may have a role in systemic inflammation. And as a result, microbiome-based treatments are being explored to reduce inflammation, not just in rheumatoid arthritis, but other similar autoimmune diseases. If you're not familiar with probiotics, just some context. They are live bacteria that make up the ecosystem in our gut. You may have heard of them before as being referred to good bacteria, bad bacteria. And these microorganisms are found throughout the gastrointestinal tract from mouth to anus. They work by pretty much maintaining the healthy balance in the biome of the bacteria, increasing the number of beneficial bacteria while inhibiting harmful bacteria. So their role is to help break down and absorb nutrients, promote the production of antibodies, they activate particular immune cells. Some may even have anti-inflammatory properties. Now, we often find these in food sources like your yogurt, kefir, sauerkraut, kimchi, but they're most commonly found in sources like supplements, most commonly consumed as supplements as well. So they're known for supporting gut health, improving digestion, but also enhancing the immune system and how it functions. They do have strain-specific effects, meaning that not all probiotics are the same, nor do they work in the same way. Lactobacillus acidophilus has been widely studied for its effects on osteoarthritis, while Lactobacillus casei, Lactobacillus rhamnosus, and Bacillus coagulans have been explored for their effects on rheumatoid arthritis. Now, this is just the tip of the iceberg here because there are so many other probiotic strains involved. Between 2021 and 2022, there was actually a randomized controlled trial that investigated the impact of a probiotic on pain hypersensitivity. So this is where probiotics come into it. They looked at 60 participants aged between 50 and 90 years old with hip or knee osteoarthritis. So they were either assigned to the probiotic group or a placebo group, and they received these alongside their usual medical care. The intervention lasted 6 weeks with assessments conducted at baseline, post-intervention, and 1-month follow-up. And there was actually findings in changes of pain intensity. There were changes in gut microbiota composition, and secondary outcomes included pressure pain threshold, lower limb function, and levels of inflammatory cytokines. So results showed a slight reduction in pain hypersensitivity in patients with knee osteoarthritis, which could have been influenced by changes in the microbiome. So the findings were super promising. it did suggest that probiotics could potentially serve as a complementary approach to traditional treatments. But there are so many questions that have come about from this, such as identifying the most effective strain for osteoarthritis management. What is the optimal dosage? What is the duration needed for its benefits to actually manifest? These details are still not well established, nor are they understood. And there's a lot of variations in someone's gut microbiome. So there's going to be a lot of challenges to understand this, because there's individual variations in microbiota, absorption, metabolism, there's genetic differences. So further research, it does aim to develop targeted therapies by identifying specific strains, doses, and treatment lengths. But these directions could lead to more personalized and potentially more effective probiotic therapies. But it's still an ongoing area for investigation. Whenever you are considering new therapies for arthritis, a personalized approach is always essential. So arthritis encompasses a wide variety of types and symptoms. Each person can respond differently to treatments. And so it's really important to select therapies based on not just the type of arthritis, but the severity, the pattern of symptoms, and overall health considerations. So a tailored approach, when we say person-centered, it means working with your healthcare providers to explore a combination of treatments such as medication, physical therapies, lifestyle changes, and potentially new or experimental therapies. So, for example, therapies like biologics or gene therapies, they might be more effective for inflammatory types of arthritis, whereas regenerative therapies might be explored for osteoarthritis to help protect and restore cartilage. So individualizing the strategy is always going to provide a better symptom and disease management. And there are so many clinical trials that are available for arthritis treatment in Australia. And there are a few main resources to help connect you with the ongoing research if you ever were to get involved. So the Australian Clinical Trials, Australian New Zealand Registry, and then Arthritis Australia, and ourselves. We occasionally share opportunities to participate in research studies. So we don't conduct the research ourselves, but we can help promote relevant research opportunities. And so I'll make sure I'll include some links to those databases and registries in an email following this webinar. And so in summary of this presentation, disease-modifying osteoarthritis drugs, while they could offer new therapeutic targets aimed at restoring quality and function of tissues affected by osteoarthritis, there's still a long way to go in terms of the research. So always stay critical and vigilant whenever you're hearing about promising new treatments in the news or in articles. The preclinical results always, most of the times, very promising, but often they're in the very early phases of clinical trials. And there are regulatory and safety considerations that remain. But if you do have questions about how they work or if they're going to be relevant to you, you can always ask your primary healthcare provider, being your GP or your rheumatologist. So next week, Professor David Hunter is a renowned rheumatologist at the Royal North Shore Hospital and leading expert in osteoarthritis. And he's going to be joining us to present the research on prevention of osteoarthritis. And so this is one of the first prevention-focused clinical trials aimed at helping individuals with occasional knee pain and reduce their risk of developing knee osteoarthritis. So he's going to be delving deep into the osteoarthritis burden, current inappropriate care, where should we be going, and new research directions. And so he'll be speaking to his latest clinical trial, the TOP study, and share some information on how you can get involved. In addition, I'll be sharing some information about this study in the email following this webinar as well. If you have any questions for Dr. Hunter already, I would love you guys to send them through to health@arthritis.org.au. so we can give you the opportunity to have those questions answered. So next Tuesday, the 18th of February, 6 p.m. New South Wales time and 5 p.m. Queensland time. You can register today, and we'll provide you with a direct link to get involved with that. So what I'm going to do is I'm going to open up the floor to some questions now. So I just pause the recording.